Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm very excited today to be talking with Dr. Daniel Hoeffer, a family physician in the Sharp Steely system in San Diego, California. Dr. Hoeffer, thanks for joining with us today.
Happy to be here.
So, Dr. Hoeffer, I'm going to let you tell our listeners about your programs, and then we'll get into some detail about them as we go.
Okay, great, Larry, and thank you for having me. Just so you know, I'm the Chief Medical Officer for Outpatient Palliative Medicine for Sharp Healthcare. I'm a family physician who still practices every day for Sharp Rees Steely. But I've created two programs, one with my colleague Susie Johnson, and this is mostly for the advanced elderly simply because I've worked in that space for over 32 years and never been satisfied with the care that we provide to the advanced elderly. The first program I created with my colleague Susie was a program to help people as they advance through the process of aging without having to use the hospital as a tool for decompensation care. The problem with healthcare as it exists now is not that we are not very professional in the care that we provide, but it is a fundamental flaw in the construct for which we apply that care. And what that means is that, we do a good job when our patients get broken and sick and then we fix them. But that's archaic. We are in an era when we should be able to keep patients from getting sick in the first place. It's the same principle we use for pediatrics, just applied with adult anticipatory guidance for advanced illness. And so what happens with our first program, called the Transitions Program, which is a pre-hospice service where we bring care to patients, homes, or whatever their place of residence. They continue to see their primary care physicians and their specialists, but we layer palliative medicine strategies on top of that and keep these patients out of the hospital. And we have been so effective and proactive in our care, we've published research twice now, that 65% of cancer patients under our care, even when they're receiving therapy, never see the inside of the hospital. 66% of dementia patients receive care in their place of residence, get improved symptom management, community and caregiver management, never see the inside of the hospital. COPD patients, 60%. And for heart failure patients, it's 56%. So imagine that. The old paradigm used the hospital as a tool to manage decompensation services. The new paradigm is manage your patients so aggressively and so proactively that they get to live at home and die at home without using the hospital as a tool for decompensation care. Now, that philosophy of proactive management, we just moved that even further upstream. So we went from hospice to palliative medicine community-based care to another service that I invented called the Gero-Palliative Evaluation. And this tool looks at 6 domains of care to define who is at risk for the unintended consequences of hospitalization, whether it's for a surgery or just for some type of hospital therapy. We've all had the experience where a patient goes to the hospital and they don't come out quite the same functionally or quite the same cognitively. Well, guess what? We know how to quantitate that risk. And by getting full disclosure and advising and evaluating our patients appropriately, we can define that risk, and patients and families make better choices. And even if they do go to the hospital, there's things we can do to protect our patients. One of the problems with healthcare as it exists now in that regard is that we are so siloed in our care, we don't understand the consequences of care outside of our silo, and this helps to redefine our care not only in what we're doing for our patients in front of our face, but what happens to them a week later, a month later, 6 months later, or 12 months later. And I'll give you a simple example. Most providers don't know that when a patient develops hospital-induced delirium in advanced elderly patients, meta-analyses of research articles show that they are 12.5 times more likely to be diagnosed with dementia in the next 4 years. So what could you do to prognosticate who's at risk of developing hospital-induced delirium, and what would you do to stop that from occurring? So that's program number 2. So I hope that gives you enough information to start a conversation, Larry.
Absolutely, absolutely. So, first of all, I want the listeners to understand. I believe your work has recently been recognized with an Innovators Award.
Yeah, we have won the National Association of ACO's Innovators Award. We've won 2 Circle of Life Awards. We've been invited to international conferences around the world. So we just won the Certificate of Distinction from the Joint Commission for our community-based palliative medicine program.
That's wonderful that you're getting that recognition. I know you've been working on this for a long time, and it's a long time coming. So I'm very happy to hear that. You know, I think one of the things when I talk to people, I tell people about your work. I say, hey, you know, I know this family physician who's more or less eliminated the need for hospitals with frail elderly as they approach end of life. And people look at me like I'm absolutely crazy. And I say, no, it's true. And so what you just talked about is hospitals still play a role, but a significantly reduced role. And I'd like you to comment on this. I think for many people in this country, the assumption is that more care is better care. And they don't appreciate, especially with frail elder folks, the negative consequences that can happen when you're lying in a hospital bed or when you're spending days in the hospital and having these transitions from home to hospital to home. Could you comment on that?
Yeah, well, you brought up a multitude of issues with your sentences there, but I'll start from the beginning. Yes, it's absolutely true. As that you get older, there are significant unintended consequences of hospitalization that people don't know about. And in fact, there's at least 23 documented harms of hospitalization. These are not medical errors, these are medical risks. And so, for example, when you put an elderly patient to bed, unlike you or I, we lose about 1 to 1.5% of our muscle strength per day. They lose 5% of their muscle strength per day. So when you have a patient, for example, with the clinical syndrome, geriatric frailty syndrome, that goes for surgery, who you can prognosticate will be in the hospital 7 days, that means a 35% loss of muscle strength. If that patient was already walking around with a cane or a front wheel walker, you should expect that they will end up with a significant decline, maybe being wheelchair bound or bed bound or some other physical decline, and that is evidence-based medicine. And a lot of people don't know about these issues. Having said that, to move up even further, because we're so used to in fee-for-service healthcare using the hospital as a tool historically for decades, even centuries, to manage disease processes, we're not used to thinking that we could be so proactive in our management skills that we can anticipate what's coming for a heart failure patient. Learning the professional skill of evidence-based medical prognostication is a lost art, and it used to be the number one valued skill of Hippocratic physicians. But we lost that during the medical technical revolution. And physicians forgot that by foretelling what's coming, we can proactively manage patients to either eliminate or ameliorate the consequences or need for much of the care that we apply. And much of that care has unintended consequences like the functional loss I talked about or the cognitive damage I talked about. Think of hospitalizations and surgeries and medications in the advanced elderly like chronic traumatic encephalopathy in football players. How many hits to the body can a patient take before they have permanent cognitive damage? And we are learning that when you lose your physiologic and cognitive reserve, you cannot take an indefinite number of hits.
Fascinating. So when you talk about the lost art of prognostication, could you give me an example, maybe a patient story, where your prognostication skills made a difference?
Sure. Well, I can. I do it daily in my office. I sit with my patients. I go through a dural-palliative evaluation that I think should be a primary care skill. I personally think this is something that should replace the physical every few years so patients know where they are in the geriatric life cycle. You know, I remember starting in my medical group, I used to go to the neonatal ICU and to children's hospital and the adult hospitals. But in the children's life cycle, if I treated a newborn like an adolescent just because they're all pediatric patients, I would have lost my license. When you go to adult care, but you don't differentiate between a patient who has physiologic and cognitive reserve, a patient who's starting to lose that reserve, a patient who's declared themselves as pre-terminal, we treat those all homogeneously as one medical group, and they are not. They have different physiology and different psychosocial needs. So if you take a patient, for example, who's starting to become forgetful and cognitively declined, and you tell them, look, we can do that surgery, but you're 500% more likely to develop hospital-induced delirium. These are medication changes we can do to protect you. These are things we can do while you're in the hospital. If you want to go and do it, this is what we can do. But you have a higher risk of coming out of the hospital not being cognitively intact. And here's some information a lot of people don't know. This was just published about 3 or 4 years ago in JAMA. It was about cardiology procedures. When you send 60-year-olds, 60, that's not old to me anymore, but you send them to open valve replacement or coronary artery bypass grafting, if they don't develop delirium, 1 out of 5 will have statistically significant decreases in their MMSE scores at 1 year. If they had delirium, it's 1 out of 3. And many providers don't know that. It gets worse as patients get older. So, and if you look at the metrics for which we evaluate research, when was the last time you saw a research article about a surgery talking about how much cognitive decline, functional decline, institutionalization, or emotional or financial burden the patient became to their family? These are not traditional metrics for which we evaluate healthcare, and they're the most important metrics to our patients and their families. And we can forewarn them.
So could you comment, one of the challenges that people, the children of frail elders, the adult children feel is they mom or dad is approaching the end. And they're just hoping that one more surgery or one more intervention of some kind will buy them some quality time. Could you speak to those folks? I mean, that's a real dilemma for them to forego treatment that they believe might give them some more quality time with their loved one. Could you speak to that?
Sure. So I had an 86-year-old woman recently, had a arthritic knee. She was walking with a front wheel walker, and she had some mild cognitive impairment, not quite demented, but she was slowing down. She could easily be evaluated as a frail patient. And although we can absolutely fix her knee and the mechanics of her knee may work better, the risk of cognitive and unintended functional damage after the evaluation and a full disclosure discussion with the family, they decided to keep her out of surgery, keep her on the 3-hydrocodone a day and low-dose ibuprofen, and keep her in the front wheel walker because they did not want to risk accelerating her cognitive decline.
Those are really tough choices. I can imagine those are challenging conversations. I think it's only fair to let the listeners know you do not practice in a fee-for-service system that oftentimes gets in the way of the ability to provide this kind of care. Could you speak to that issue?
Well, 70% of my care is capitated, 30% is fee-for-service. I give the same discussion to every patient and family, and I don't discriminate between anybody regardless of their insurance. And the responses are pretty much the same, which is, and this is the one word I hear the most, finally, somebody is telling us the whole story. Because they've seen it on some level. They've seen their parents go to the hospital and not come out quite the same, even if whatever they went in for was fixed. And they didn't know that doctors could quantitate that risk or evaluate that risk or inform them. And so that is available to be done. I think the community is begging us for this. They just don't know. I used to work in nursing homes for 25 years, and I said, no, you don't have to go back to the hospital. And they said, really? And I go, no, you don't. We can just treat her as best as we can here and keep your loved ones comfortable. And they go, thank you. Doesn't mean everybody wants that, but there are plenty that do. And plenty of the elderly, if you look at the medical research, they are prioritizing quality, not quantity. And so they would rather not take a chance of losing their cognitive abilities, even if they can maintain or improve some other functional status.
So Dr. Hoeffer, I want to thank you for talking with me today. I'm really, I've always been impressed by your determination to proactively help your patients to have the best possible life that they can have. Thank you for the great work that you're doing.
Well, thank you, Larry, and I just want to leave you with this thought that I have long believed that it is not our patients' responsibility to get sick so that we can finance ourselves. And healthcare should not be about fixing things that never should have broken in the first place. I think we have a long way to go to get to where we really should be, but we can do it.
I think so too. Thank you very much.
Great. Thank you, Larry.